All right, Chris, we're live on YouTube. So Morning, Craig.
Good morning. How are you?
Can you hear me all right?
Yeah, I hear you just fine.
All right, perfect. Okay.
Hey, Craig.
Morning.
We're gonna have a um, new person joining us from my team, Avery Adams. She's fresh from NKU's MPA program.
Awesome.
She's been here since her first day was January 6th, with, as you know, was the storm of 2025, and then she didn't get in the building until January, I think 8th, Wednesday. So,
Better late than never, right?
yeah. But we're happy to have her.
Good.
She'll be assisting me with the health insurance board.
Good. How's the salary survey coming?
We didn't get as many as last year. We got 33, I think. But I really think, and this is just it seemed like everything around December this year was everybody was late on stuff because Thanksgiving was so late.
Mhm.
You know, like even some social things, people were like, "Oh my gosh, I don't have time to do this." Like, I mean, Thanksgiving was as late as it could be, and so
Can you
usually people
send
do all their shopping, and and people were. It's like the break in between Thanksgiving and Christmas was so short this year. I think people didn't anticipate getting all these things done,
right?
but
Can you send me a list of respondents so I
yeah,
can compare it to last year, and then maybe I'll get with Dina and we'll make some phone calls.
we had. I think it's only three less. I mean, we had 36 the year before, but
Yeah,
we
but
have
depending on who
33.
those three are, I mean, if it's Fort Mitchell and Ellesmere missing, then that messes up my numbers really good because they're
Yeah.
part of the 12 I tagged to. So
Were you able to access that link for the meeting materials?
oh yeah, and I printed it all out because I can't
Great.
read on the screen. So yeah, I had no
Well,
problem. We'll see what
good,
else
good.
happens.
Well, I'm trying to minimize sending large emails out, and this was 12 documents. And I was like, let me try our link to our SharePoint. It has to go in our SharePoint anyway. So if not, I have an email stand, like queued up, ready to go for anybody who doesn't have
Good.
the accessibility to do that. So and then for the interlocal agreements, um, I got stuff ready to go to track those and collect those whenever they pass them, right? They have to go to their council. Is
Has
that
to go to
right?
their council, their board, their fiscal court. It just depends on what the agency is, and it's
Yeah.
different for the agency. So like the counties and the cities should probably pass it by ordinance, but if they pass it by resolution, I'm gonna let an attorney argue over that, not me.
Okay.
But all the special districts will pass by resolution, so.
Okay.
it- But I'm not ready for them to start passing it quite yet. I wanted them to take a look at it and come back to us at our meeting in March with any changes before we released it, because they should be able to adopt it between March and in June.
Okay.
at any jurisdiction, unless somebody has a total hiccup.
Very good.
Okay, there we go. Hi, guys.
Hey, Lisa.
How are you?
Good.
Good.
I'm getting over this cold finally. I had it for a long time.
Oh, gosh. So 2025 hasn't been fun for you between the weather and being sick, huh?
Yeah. And we've been really busy here at the ad too.
Oh,
Really
gosh,
busy.
of course. I know. To me, it feels like January has been going on a lot longer than a couple weeks.
I agree. I feel that way too. Hey, Terry.
Hey.
Morning.
Hey, Brett.
Morning. Hey, Paul.
Morning.
Morning.
Hey, Paul.
How y'all doing?
Good. How are you?
Doing well.
Was everybody able to access the meeting materials through that link that I provided?
Yes.
So, yeah.
Yeah,
Okay.
that was really nice. Thanks. Made it easy.
Well, yeah, I'm trying to not have such large emails anymore, and I think we have the technology to use these links, so I think it works out well.
Yeah. I also noticed you put the next meeting date in the agenda, and that's helpful.
Well, it always comes down to at the end of the meetings, everybody's looking towards me, and I have to
Yeah.
run to my board with all that stuff on there.
Yeah. No, that was good thinking.
Good. Hi, Brandy.
Hello.
Quick question. Did you
Morning.
get the shirts for Steve from AFOX? Right, but you got them from AFOX. I'm asking because I don't have a bill for them and I need to call them and find out about a bill. Okay, so, all
Hey,
right.
Brandy, I think you're. Can you mute? We're hearing the background conversation.
Okay,
Yep.
all righty.
Thank you.
Thank you very much.
Full house.
I'm gonna go fill my water, Chris, and I'll be right back.
Okay. If you're able to change your name on here to like after your name, put your organization. It helps me with quorum. It makes it quicker for me. Hi, Carissa. How you doing?
Good. How about yourself?
Pretty good. Who are you with again?
Crescent Springs, Phil Hills Fire Authority.
Thank you. Is somebody from Warsaw on the call? Oh, there's Harry. We're good. Hi, Harry.
Good morning.
Morning. You're on the road today.
Yeah, got a lot going on today.
All right, we have quorum.
Yep. Let Laura get in. All right, we'll go ahead and get this meeting started. So I'll call to order the Public Entity Joint Health Insurance Board meeting for January 17, 2025. Just a reminder to board members, state open meetings law requires your video feed to be live. And if we lose you, we have to wait for you to come back. So if you're not live, we can't count you towards quorum. So with that said, we'll go ahead and move along. And Mr. Secretary, do we have a quorum?
Mr. Chairman, yes, we do.
Okay, great. Next item on the agenda is the approval of the agenda. That was sent out as a link, a part of the link to a folder full of documents. Today's going to be a long meeting.
I'd like to make a motion to approve the minutes.
Okay, great. Motion
I'll
made
second.
Second by Harry. Any changes or objection? All right. Hearing none, all say, if you approve, please say aye.
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 Any opposed? All right. Next item on the agenda is the approval of minutes.
So moved.
Motion second.
Second.
A second.
Great. Any discussion or changes? Hearing none, all in favor, please say aye. Aye.
Aye.
Any opposed? Okay, great. Next item on the agenda is the finance report.
All right, before I share the financial report, I just wanted to make a few comments. Brooke has the 6-month plan review, and she's going to go into that in detail. But just in general, we're projecting that this year you'll be down 11% on a per employee per year basis from where we were last year. And one of the reasons for that is that high claimants are projected to have less of an impact this year than last year. You've had 8 high claimants, and 7 of them have risk profiles that are actually improving, which usually bodes well for the plan. And the second quarter has been significantly less in terms of claims expenditures than the first quarter was. So those are just some high-level observations. And with that, I'll share the financial report. Can you see that? No? All right, we'll try again.
You should be able to have the access to share your screen, Lisa.
Yeah, I think I just needed to click one more thing. How's that?
It's starting.
Okay.
Oh, there we go.
All right. Okay, so this is a report from July through December of this plan year. And you can see that the attachment point, so that's your maximum claims amount per your stop loss contract, is about $3.1 million for the first 6 months. And you have had in-network medical claims of about 1.4 million. Out-of-network medical claims of about 638,000. Pharmacy claims of about 433,000, fixed costs of about 561,000, for total costs of about $3.3 million. We've got some pending stop loss reimbursements now of about $10,000. So after you take those into account, total plan costs through 6 months have been about $3,035,000, and we've collected premiums of about $3,037,000. So we are running a bit of a surplus at this point of about $1,700. And to that, we add pharmacy rebates, which through the first 6 months have been about $71,000. We're capturing some interest now, and that has been about $20,000. The Corey fees cost about $1,700. That's a little Affordable Care Act tax that the plan has to pay every year. And we've had limited purpose specialty drug HRA claims of about $55,000. And when we add in the reserves from the prior years, we are sitting at approximately $1.8 million in reserves. And through 6 months, you're running at about 77% of your attachment point, which is great. I'd like to see it about 75 to 80%. So far, so good. Any questions?
Nope.
All right.
Great. Thank you, Lisa. Appreciate that. I'm glad to hear we're doing good, because the last couple of years, we've kind of been slipping a little bit, and I started to put together my very first draft of the budget. It's draft 0. It's the budget I look at before I show it to the mayor, and I put in 15%. So because I didn't know what we were going to be looking at with us being down earlier in the year. So I'm happy to hear we're heading in the right direction.
Right.
So next item on the agenda is our agenda items, and MedBin is up for the 6-month plan review.
Okay, can everybody see my screen?
Yes.
Yes.
Okay, before I get into the review, at the beginning of this year, we updated our reporting. So I don't think that you have seen our new reporting package. It just gets into additional details that some of our clients were asking for. We have different dashboards that I'll be showing you. It's a little bit longer. I'm not going to touch on every single thing. But if you have questions, let me know. I did provide highlights throughout the reports because some of the pages are a little bit busy. So it helps in that aspect. But if you have any questions, feel free to interrupt. Just taking a look at the first page over to the right-hand side, you can see July through December data. You've had about $2 million in medical claims and about $460,000 in pharmacy claims. That figure does have the specialty use HRA claims of about $55,000 added into it. So when you add those together, you're right around 2.5. You do have about $10,000 in pending stop loss reimbursements. But when we take those claims and annualize them out through the end of the year, we're projecting you to be down about 5%. You have 8 large claimants on your plan so far this year. And last year at the same time, you had 7. So you've had an uptick in your large claimants year to date. We'll continue to watch that. But when we look at your claims on a per employee per year basis, we're projecting you to be down 12%. And then when we add in your fixed costs, we're projecting you to be down 11%. Any questions?
No.
This is just a quick snapshot into your financials. Again, it has your medical, pharmacy claims. That those figures are a little bit off because of the specialty, the limited use HRA for the specialty medications. Down below, you can see from a place of service standpoint, outpatient claims continue to be your largest area on a per member per month basis, which is normal. Over to the right-hand side, you can see the plan has paid about 93% of the spend, where the employees have paid about 7%.
Hey, Brooke, back on the previous half of the page, when you said these numbers were off a little bit because of the HRA, is the HRA included or not included in these numbers?
So on this, the HRA figures are included.
Okay.
There's you had $54,000 in specialty HRA claims. So we went ahead and added them to this amount. So they're included in all these numbers. We just can't include them in our data analytics portal.
Okay. Thank you.
So you can see here, we're saying you had about $459,000 in pharmacy claims. Down here, you can see it's only pulling 404. So this is lower than what it should be.
Thank you.
Yep. So just looking time period to time period, if you look on page 3, you did have an increase in the number of employees and members that you cover under your plan in the 6 months of this year compared to the prior 6 months. From a claims standpoint, overall on a gross basis, your medical claims are up about 8.5%. Pharmacy claims, again, are a little bit off. But when we look at your net numbers, it's about 10.5% increase from last year to this year. And then on a per member per month basis, it's about 2.6. Okay, taking a look again at place of service. So pharmacy claims have stayed pretty steady or below mark. Your inpatient claims jumped from last year to this year. You're at $117 per member per month. You're still below our benchmark, but you did have a 42-day NICU stay. So that's part of the reason that your inpatient claims have jumped up this year. Your outpatient claims dropped. Last year you were at 309. This year you're at 275, and again below our benchmark. And then office visits went up just a little bit, and you're above our benchmark on your office visits. If I look at total medical and pharmacy on a per member per month basis and compare it to last year, it's about a 1% increase.
Nice.
And then taking a look at some of the trends. So again, this is just looking July through December of this year. But again, you've had more people have a claim. So you had 589 claimants and you had about 5,313 claims. You're going to see that just with the increase that your group saw in your enrollment. Again, your enrollment went up quite a bit, about 9% on the employee. Here's your enrollment count up here. So you had 340 employees, 681 total members. Okay, and then if you look at your average claim cost, again, this is just medical claims, no pharmacy is included. You're at $390 for your average claim cost. Last year you were at $377, and our benchmark's $424. So you're still performing better than our benchmark. And then directly below that, it's just on a monthly basis. You can see any fluctuations on a month-by-month basis below that. Same metrics, just monthly. Okay. This just breaks out your coverage tiers, so you can see employee, family, employee plus dependent, and then employee spouse claims. A lot of our groups like to look at this when they're thinking about making premium contribution changes. And then if you take a look at your top hospital providers, The St. Elizabeth is broken out by their tax ID number, so you can see different locations there. The main facility represented about 31% of the spend, or about $344,000, followed by Good Sam. And then Meadowview. Total facility spend, though, this year, you were right around 1.1 million. And very similar to last year. So last year you were about 1.17, this year you're 1.12. So not much change on a facility standpoint. Any questions?
No.
Okay. Taking a look at your inpatient admissions, you had 9 total admissions from July through December. That is actually a reduction from what you saw in the prior 6 months. You had 13. But your inpatient days were up. You had 99 inpatient days. And the reason that that is up and the cost is above our benchmark now is because of this NICU stay. It was quite a long NICU stay. It was 42 inpatient days. Other than that, you had 2 medical admissions, 3 surgical, and 3 maternity. Okay. And then taking a look at your outpatient admissions, Children's was the top paid facility. They had 4 MRIs, about $25,000 paid, followed by St. Elizabeth. Just breaking out the cost of your MRI and CT scans, though, even with Children's being the top paid facility, you're still below our benchmark. And then emergency room, I have quite a few pages for your ER visit analysis. So we'll start, you're probably familiar with this page. It just breaks out the average cost of the ER visits and what the member paid versus the plan. You did have one individual that went to the ER more than 6 times. It was a female 28-year-old. It was a spouse on your plan. Appear to have renal issues. She went a lot for UTI, abdominal pain, GI, dizziness, but total she accounted for 8 visits. Other than that, only 5% of your ER visits were considered potentially avoidable. Our benchmark is 15. So really that individual going 8 times is somewhat of an outlier, because everything else that I was looking at under your ER visit analysis looks really good. If I look at the severity of them, the majority of them are falling into a very high or a high category. So medically, necessary to be going to the emergency room. And it breaks it out by ER visits by month. And then this next page, again, breaks out the severity of them. What's nice about this is it compares your group and your visits to our benchmark. And you can see when it comes to life-threatening ER visits, you're above our benchmark. Not necessarily a good or a bad thing, but again, people aren't abusing the ER when they really need to go. High severity, just a little bit below. The area that you jump up is it was the over 6 visits, you're going to be above our benchmark. All of the ER visits occurred on a weekday, so none of them were on a weekend. Sometimes that's a factor into why people utilize the emergency room versus like a primary care physician. And then again, I mentioned about 5% of your visits were potentially avoidable, and our benchmark's 15. On this page, we're looking, it just breaks out additional details, why individuals went to the emergency room. If you were a group of 1,000, what that would look like, and it compares it to our benchmark, and then it also has the allowed amounts. I'm not going to go over that in depth, but this is another nice report that we're showing now. Again, it not only shows individuals over 6 visits, but it breaks it down to anybody that goes 2, 3, 4, 5, or 6 times. So when we're looking at individuals over 2 ER visits, you had 6 individuals. That's below the benchmark, which is good. Over 3 visits, you only had 1 individual. That individual went 3 times. Again, below our benchmark. You didn't have 4 or 5 visits, but then you had the individual with the 8 visits. Okay. And then we also provide, if an individual, instead of going to the ER, went to an urgent care or an office visit, what the potential for savings would be. And it's pretty low, especially compared to your group last year. The potential for savings is about $1,700, whereas last year you were about $20,000.
Wow.
This is a new report that we're showing. It takes a deeper dive into behavioral health and what the actual diagnosis are of individuals that have a behavioral health diagnosis. So on your plan, we know of about 105 people that have a diagnosis, a behavioral health diagnosis. And of those individuals, your total spend is right around $98,000. You're higher than our benchmark. The numbers directly underneath are comparing you to our benchmarks as well as the cost. But that's not necessarily a bad thing, especially with after COVID, we're seeing a spike in that, and you want individuals to get treated if they have a behavioral health diagnosis. Mood and anxiety disorders is your top diagnosis, followed by mental health conditions outside of mood and anxiety disorders, and then depression. And you can see the majority of where your members are going is an office visit. And then you did have a couple ER visits stemming from a behavioral health diagnosis. The good news is when I look at individuals that are diagnosed with chronic depression, we don't know, and this is all based off of AI data analytics, we don't know of anybody that's diagnosed with that condition that's not on an antidepressant. We're also taking a deeper dive into cancer. So on this page, you can see the top 5 cancer, the prevalence of that cancer, and then the average spend. We know of about 13 people on your plan that has cancer. Their average age is right around 50. Over here, you can see the majority of the individuals that we know of that have a diagnosis of cancer are employees. And it's a 50-50 split between male and female.
Didn't expect it to be that even of a split.
Yep. And then down below, you can see utilization at different providers with a diagnosis of cancer. So a lot of individuals are going to St. Elizabeth. Any questions?
No.
Another hot topic is diabetes with the new medications or the medications that everybody wants to get on. So if we're looking at the number of people that we know of with the diagnosis of diabetes, we know of 62 individuals, only 1 individual that's potentially undiagnosed. You have 66 diabetic medical users and 25 high-risk diabetics. the majority of the individuals that are diagnosed with diabetes is a type 2 diabetic, which is typical. And if we look at down below, you can see, let me zoom in. There, that might be easier. When we look at your medical claims to the comparison period of your diabetic population on a per member per month basis, the medical claims went down more in line with our benchmark, but the pharmacy claims did jump up a little bit. Ozempic is your top paid medication for diabetes, followed by Jardiance and Mounjaro. You didn't have any Mounjaro claims last year. You did have one, I think it's one individual that jumped up on Mounjaro this year. And then by place of service, just of your diabetic diagnosis, most of them are getting treated in the office. And then chronic conditions, we previously showed this, but this just shows you your top chronic conditions on a per member per year basis. You do have an individual with end-stage renal disease. You can see compared to the benchmark, you're well below our benchmark for the amount that you'll have to pay for this individual. And then chronic kidney disease is what CKD stands for.
What's CAD stand for?
Coronary artery disease.
Ah, lovely.
Yeah. So you have this doesn't show the number of people. I think there's only one individual with coronary artery disease and one individual with chronic kidney disease. Okay. So the first page of this report, it does break it out. It does break out their office visit, ER visits, and admissions if they have the diagnosis, or if they have a chronic condition diagnosis. This first page is the first 6 months of this year. The next page is the prior year, so you can see how those chronic conditions have fluctuated. And then we also show you our benchmark, so how you stack up to our benchmark. But really, all of that is highlighted right here. All right. Moving on to large claimants. So for your group, we consider an individual to be a large claimant if they're over $42,500 in claims. That's half of your specific deductible or what you're responsible for each individual on your plan. You had 8 individuals meet that threshold, and the total claims paid for all 8 of those individuals was right around $742,000. This year, you did have a large dependent child. This is your NICU admission. It was about $173,000 that was paid for that member. The good news is the prospective risk score on the majority of all these 8 people are going down, which typically means in the future that those individuals' claims will go down as well. The only area that you're seeing the prospective risk score jump is on this dependent, the last one on this page. It's an 8-year-old dependent child that has autism.
Wow.
From what I can see, all these individuals are still active under your plan. And again, total claims are about $742,000. Last year, you had 7 individuals and your total was about $627,000. So you did see an uptick in the amount paid and the number of members that we consider to be a large claim in the first 6 months of this year. Any questions?
Could you scroll down just a little bit to get the table to pull into the thank you. Sorry, I was
Yep.
just reading some of the dependent stuff.
Yep.
I was like,
Yeah,
ooh,
so
How close are we?
we never
Sorry.
put names
Well,
in the report, but
naturally.
we do put if they're currently active, what relationship, their gender, and their age.
Nice.
Do you know how close we are to meeting the aggregate deductible?
You've met it.
Okay. So anything that's paid on these individuals, these high claimants, will be reimbursed. Is that correct?
Yeah, correct. You currently have about, well, at the end of December, we had already requested about $10,000 in specific reimbursements. So yeah,
Okay.
that aggregating specific deductible is fulfilled and you'll start getting reimbursements back. That's why, I don't know if I mentioned this or not. Say that claims continue on all these individuals. We had a number here. Since you've met that aggregating specific deductible, we don't want to trend all of their claims into your amounts because you're done paying for them, especially now that that aggregating specific deductible is met. That's where this $619,000 comes into play, because we don't want to take all of their claims and annualize them into the last 6 months of the year because you're going to be done paying for them.
Okay.
Okay.
Yeah,
So
there were a few individuals on the report who still have to satisfy their specific deductible of $85,000, but once they go over that, then it's money back from Stop Us.
yeah. Yeah, so the top 3 individuals have hit your specific deductible. This one's pretty close.
Okay. Thank you.
Yep. All right. And then this is just a recap in picture form of a lot of the information that we just went over. And then we also still continue to break it out. The first page is going to be on a per 1,000 basis so that you can compare yourself to our benchmark. It continues on to this page. But what I typically like to look at, especially for your group with your size, is the utilization metrics that's based on your totals, not on a per 1,000 basis. You can easily compare here your ER visits, which dropped about 12%, urgent care visits, total office visits. You can also see mammograms, colonoscopies. You did have a decrease in both of those areas this year. And then your inpatient days, again, I mentioned that jumped up, but it was mostly because of the NICU inpatient day. And then taking a look at your wellness compliance. So this was updated on January 9th. For annual wellness exams, your compliance is about a 47%, cholesterol 66%, colonoscopy, you're at about a 53% compliance rate, mammogram 64%, pap smear 21 through 29, you're at a 46% compliance, and over 30, you're at a 59%. And then we do have updated pharmacy reports that we're showing. Again, this number is not completely accurate because you had about $450,000 in pharmacy claims, but it still provides a lot of good information. You can see the majority of your scripts here are going to be generic medications, which is excellent. We mentioned that diabetic therapies were your top paid medications, with Ozempic being the top one. On this graph, you can see where it was last year compared to where it is this year. So Ozempic, the cost of Ozempic did jump up a little bit, Jardiance and Eliquis. We went over that already. This shows you a breakout, again, like we did the medical trends. This is just on pharmacy. So it's showing you how many people had a pharmacy claim and how many scripts were filled. You can see about 445 people had a script filled in the first 6 months of this year, and the number of scripts that were filled were right around 3,784. Your average script cost did jump from last year to this year, but again, you're below our benchmark. What's nice also about these reports is it shows your copay breakdown of your scripts. So where the majority of them are falling from a dollar standpoint. And then we also break that out like we did on the medical side, but on a monthly basis. This is also a new report. You can see the largest dollar increases that you saw on medications from the prior period. Mounjaro jumped up. You didn't have any Mounjaro claims last year. Ozempic, again, had about a 26% increase. Down here, you can see the top 20 medications, what ranking they were previously, and if they jumped up, and how many members we know taking those medications. And then it does the same thing with therapeutic classes. And then we break out your age based on your plan paid per claimant and per script. You can see with your population above 50 is really where on a per member per month basis, your cost goes up. And then we show, this breaks it out between therapeutic class, and it shows you what medications fall under each one of those therapeutic classes. So GLP-1s, you can see factor inhibitors, so typically a blood condition, insulins, diabetic supplies. Okay. What's also nice about this report is it will show you the paid amount for medications versus days supply. So you can really dig into what the actual cost of the medication is on a day's supply. And that is pretty much it.
Yeah, Brooke, can you go back to the page that has the pie charts? There you go. Okay, yeah, so what I wanted to point out here is that in the pie chart, the blue sections, that is the amount of your plan paid that is represented by specialty meds. Now, of course, this doesn't capture the specialty drug HRA, but your specialty spend is about 5% of your overall pharmacy costs right now. And before you put in this alternative sourcing program for specialty meds through our Excel centers, specialty meds were 34% of your pharmacy cost. And at this point in time, that program is keeping about $500,000 in specialty meds off of your plan. So a little later on the agenda, we're going to talk about possibly changing vendors for that program. But I just wanted to point out that regardless of which vendor you use, that has been a highly successful program and is keeping your pharmacy costs under control in a huge way.
A lot of good information to digest. Anybody have any questions?
Just real quick, as far as the well living compliance letters, are they're going to be going out soon to the membership?
Yes, those.
Do you know?
Yep, I'm here. Sorry. Yes, those were being finalized last week and should be going out here. I would say next week.
Okay, thank you.
Any other questions? Hearing none, great, thank you. Next up is a new 3-year contract for access to St. Elizabeth for plans 9, 10, and 11.
Okay, thank you, Mr. Chairman. So Sherrill Morgan has a subsidiary called Employer Advisory Services, and Employer Advisory Services, EAS, is our contracting arm of our company. So what they do in large part is negotiate direct contracts with providers, including some of our local hospital providers. And we have negotiated a new 3-year contract with St. Elizabeth. And one of the really interesting things and potentially beneficial things about this new 3-year deal is that for the first time, they are going to give significantly better discounts to groups who will put some modest steerage into their plan design. I'll show you what that will look like when we get to plan design recommendations. But for very minimal change to your plans, you can see some really big savings. And I'm going to show you a summary. I can. Hold on a second. Okay, hang on, almost there. Okay, should be coming up. Okay, can everybody see this chart?
Yes.
Okay, so this is a summary of the reimbursement rates that St. Elizabeth has given our plans going back to 2020. And the rates you see here are based on Medicare rates. So for example, in 2020 on inpatient and outpatient claims, which are the big claims that you get from a hospital, we were getting a rate of 218% of Medicare. Okay. And under the new 3-year deal, if you keep your plans the way they are right now, there will be an incremental increase, as there has been every year, in the rate. So it would be 240% of Medicare. But if you put some steerage into your plan, then you can get a rate of 216% of Medicare, which is below what you were paying back in 2020. So to go from where you are now to a 216% rate of reimbursement is what, 19%, a 19% differential on medical claims that come through St. E in the form of inpatient and outpatient. So there are tremendous potential savings there. So, you know, we would highly recommend that you not only sign on to the new 3-year deal with St. Elizabeth, but that you also, beginning in July, put some steerage into plans 9, 10, and 11. And what we would recommend that looks like is just a lower out-of-pocket maximum for St. Elizabeth versus other hospitals. And hardly anybody hits. I mean, I would venture to say that very few people, if any, have met your out-of-pocket maximum on those plans because it would take so many copays to get there. So for very little impact, you can get some really significant savings. So any questions on that?
So what kind of lower out-of-pocket are you talking?
Yeah, they require at least a 20% differential. So next year, because of federal laws, the Affordable Care Act, your out-of-pocket maximum has to be $9,100 for single. So 20% below that would be $7,280. So if you stay within the St. Elizabeth hospital system, your maximum out-of-pocket $7,280. If you go to any other hospital system, it's $9,100.
So what kind of agreements do we currently have with like Norton's and Baptist and some of the other groups?
I don't know off the top of my head. I don't think we have a direct contract with Norton.
Okay.
We have one with Baptist. And the Baptist contract is not even a percent above Medicare. It's a percentage off of billed charges.
Okay.
And that's through a network called CenterCare Direct. We do have Medicare-based contracts with TriHealth and Christ. And we can find out what those rates are, but they're going to be pretty comparable to what the all-inclusive rates with St. Elizabeth are.
I mean, the vast majority of our claims go through St. Elizabeth, but
Yes.
you know, at the same time, I don't want to unfairly punish members who just don't have access because of location.
Right. And I mean, if you set up the steerage the way we're proposing, they're not going to be any worse off than they are right now. It's just that if they go to St. Elizabeth, they could conceivably, have less out of pocket. But again, it takes so many copays to get to even not, $7,280 and an out of pocket. I mean, you just aren't going to really see that happening. But it would satisfy our contractual obligation to St. Elizabeth to have the steerage.
Anybody else have any thoughts?
And
So
with
just
this,
so I understand it, I'm sorry. So if we agree to this lower maximum out of pocket, is that the only thing that we would have to agree to
yeah,
in
I
order
mean,
for us to get the discounted rates from St. Elizabeth?
yes, you could go further and change other aspects of your plans, but I don't think there's a compelling need to. I mean, most people go to St. Elizabeth anyway, so you're going to get the benefit of these, reduced rates for most people anyhow. So,
But we're lowering the maximum out of pocket per member, so it's actually benefiting them, correct? I mean, I know we never. I would be interested to even see the 7,280 if anyone's ever even met that. Just again, as you indicated many times, that it's just based off each copay, right? And so that's
right.
each visit or
Yeah.
each
Yes, and
point of utilization.
your pharmacy copays accumulate to a separate out-of-pocket maximum. So we're talking about just medical copays here. And I mean, even if you had multiple inpatient stays, it'd be awfully hard to get there.
Oh, absolutely. So what's the motivation for St. Elizabeth? Why would they want our maximum out of pocket to be lowered in order for us to get a better rate?
Well, they want people to come there, and in their minds, when people see on their ID card, oh, I have a lower out-of-pocket maximum at St. Elizabeth, I'll go there instead of going somewhere else. I mean, that's a big deal to them.
Sure.
Yeah, it's an incentive to go to St. Elizabeth. I think it's a good idea. It saves the member a couple $1,000s potentially, and it saves the plan substantially.
Right. Exactly. It's what you call a no-brainer.
Yeah.
Yes, it sounds like a win-win.
Absolutely.
I was a little shy to ask that question, but I'm glad you did, Paul. I had the same thing going on in my head. It's like, this sounds like a win-win.
Yeah.
We get
now and again.
Carrie, what are you thinking?
Mr. Chairman, if you're looking for a motion, I make a motion to approve and authorize you to sign the 3-year contract extension. And I guess we'll have to come back and for the plan recommendations, make a second motion to change the plan.
Appreciate that motion, but I'd like to hear from Terry how he feels this impacts them down in Carrollton.
Well, yeah, a lot of our folks split the middle here, right? And anybody you see that's gone to Baptist East is probably us on our list. The number's pretty small, but it'd be nice. I wish the mayor had been able to make the call today too. But I mean, I'm fine with that. I guess just thinking it'll affect about half of us, right?
Well, I mean, they can still go to Baptist.
Sure. Yeah.
Pocket maximum is going to be lower regardless, because even the higher one has to be lower because of federal law. So,
Right.
yeah, it doesn't affect their.
Yeah, so they're going to see a win. They're going to see a win there, obviously, too. Yeah. Okay. Yeah, I'm fine.
So with that, I have a motion from Harry. Is there a second?
Second.
Okay, Paul seconds. Any other discussion? Hearing none, all in favor, please say aye.
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 Aye. Any opposed? Okay, great. Thank you. Next is a set of plan recommendations. And I guess we're going to go to benchmarking and plan design.
Yes. Okay, I'll make my benchmarking up. Okay, can everybody see that one?
Yes.
Okay, so for this comparison, we're just comparing Plan 9, which almost everybody is on. We've got a few people on some of the other plans. There's 6 plans that we offer currently. But Plan 9 has the vast majority of members. So comparing Plan 9 and RX Option A, which is the flat dollar copays, which again, most people are on for pharmacy, to a couple of different surveys. The first one is the Kaiser survey, which is a national survey of employer plans across the country, a few thousand employer plans surveyed there. And then also the 2023 Kentucky Government Benefits Survey. And we're going to be releasing the 2024 data pretty soon, so this will all be updated. But that's a survey that Cheryl Morgan conducts each year in conjunction with the Kentucky Public Human Resources Association. And there are typically about 75 Kentucky governments surveyed there. So looking at your plan compared to the national data, and you don't have a deductible and you don't have coinsurance. So, you look a lot better than plans across the country who are, mostly looking at pretty high deductibles. So the average deductible across the country is about $1,800 for single and $5,000 for family. And then on top of that, they have 80/20 coinsurance up to an out-of-pocket maximum. In Kentucky, the benchmark plan now looks a lot like your Plan 9. So a lot of Kentucky governments are doing what you're doing, which is an all copay based plan that pays based on how Medicare pays plus a percentage. Your doctor's office visits, primary care in Plan 9 are $25, which is in line with both benchmarks. Specialists, $35, again, in line with both benchmarks. Your emergency rooms at $250, which is the Kentucky benchmark, and Kaiser doesn't report that statistic. And then your prescription copays actually look better on generic and preferred brand than the Kaiser data, and also the same or better on than the Kentucky benchmark. And then your out-of-pocket maximum, which we talked a lot about, is currently at $9,450 single and double that for family. And the Kentucky benchmark is a little bit lower than that right now. Kaiser is lower, but remember on the plans in the Kaiser survey, that's a much more true number because you've got a deductible and you've got coinsurance on most of those plans. So anytime you have anything done pretty much on an outpatient or an inpatient basis, you're going to be looking at hitting, probably hitting that maximum out of pocket or coming close. So anyhow, your plan design looks really good compared to both national and state benchmarks. Any questions on that? We have a lot of data in that Kentucky survey that we can mine if any of you are interested in seeing how the plan you're on compares to specific other governments who participate in the survey. We can provide that information. We just de-identify the plans that we're comparing you to, but we'll tell you who's in the mix. Okay, so that's benchmarking. Should I move on to plan design then?
Yes, please.
Okay. Can you see my recommendations?
Yeah, I still see benchmark.
Okay. All right, how's that?
Yes.
Okay, so we're really just looking ahead to July now. That's when we make plan design changes generally. And a lot of these changes will require changes to ID cards. So that's a logical time to do it. The first one is to bring the plan into compliance with some new Kentucky mandates. And I did include a summary of those in the materials. I won't go through them here. Most of them are pretty obscure, but you are all ERISA exempt. And when you're exempt from ERISA, which is federal law, it means that you are subject to state insurance mandates. So Kentucky has passed some new insurance mandates that you are subject to, and we are always going to recommend that you make plan changes to comply with what the new insurance mandates are on a state basis. Now, I say there's a caveat to that, and that is the Department of Insurance has always taken a hands-off stance to governmental self-funded plans. And if we asked them today if they were going to enforce the mandates on your plan, I don't know what the answer would be. In the past, they've always said they don't really get involved in enforcing the mandates on governments. They're typically more interested in enforcing them on insurance companies. But in our opinion, it's a better look for your plan to be in compliance with the mandates. So, and most of these are not really impactful. The biggest impact will be from the pharmacy mandates, which I'll talk about in a minute. So that'll be our first recommendation for July on the medical plan. And then we've already talked about the 20% difference in the cost sharing. So again, that would be for July. Okay. And then the lower out-of-pocket maximums, this is because of the Affordable Care Act. This is the first year that they've actually lowered the out-of-pocket maximums. So we would recommend that you comply with that. And then Plan 6, which is your qualified high deductible health plan, we would recommend that you raise those deductibles to be in compliance with what those plans need to look like in order to have them coupled with a health savings account. We do have at least one entity who has employees on Plan 6. Okay, so that's the health plan. Then on the pharmacy side, the Kentucky mandate does a couple of interesting things. One thing that it does is says that you can't steer people to one pharmacy over another pharmacy. And we've always had higher co-pays at Walgreens than other pharmacies. So if you want to be in compliance with this new mandate, then we would have to remove that higher co-pay structure for Walgreens. And then also I mentioned you have a separate out-of-pocket maximum on your pharmacy plan, and we would recommend that you make that the federal maximum also. And then if you have mail order copays that are lower for a 3-month supply than they are at retail, then you also would have to have the mail order copay be, instead of 3-month supply for 2 copays, it would have to be 3-month supply for 3 copays. But I'm not sure if you do have that 3-month for 2 copay plan design right now. Amber, can you check on that? Do you know off the top of your head?
Yeah, I'm looking at it here. For retail, you've got the 30, 60, and 90. Mail order, and you said mail order, so you just have no, you only have one.
So it's
There's only
three
one copay.
months co-pays for 3 months supply at mail.
Yep.
Okay, good. So the only change really then would be removing that higher copay structure at Walgreens.
Yeah.
Okay, so I don't know if you want to go ahead and take action on these items. We'll be bringing them back for the budget discussion in March. So if you want to think about any of these, you can, or if you're ready to take action on, we're good with that too.
Yeah, at this point, I don't think anybody would oppose anything that's being recommended, since most of it has to do with simply complying with existing ACA or state law. So if there's no discussion about that, unless you want to talk more about the St. Elizabeth change, which I think we already had that conversation, I'm happy to entertain a motion to go ahead and make these plan recommendations effective 7/1.
I'll make the motion.
I'll second.
All right, motion made and seconded. Any other discussion? Hearing none, all in favor, please say aye. Aye.
Aye.
Any opposed? All right, thank you. Okay, next up is vendor options for specialty drug program.
Okay, so we've been doing the alternative sourcing for specialty medications for several years now through a company called RX Help Centers. And especially for the board members who are new, the idea behind this program is we exclude specialty drugs from the pharmacy plan, and RX Help Centers assist members with trying to get alternative sourcing for their medications, typically from the drug manufacturers themselves, who in about 80 to 90% of the cases have programs available to individuals who don't have coverage for the drug that they need. And then if RX Help Centers can't source the medication through the manufacturer or some other source, sometimes it's a foundation who might provide financial assistance for medication, then we've got a safety net. And that safety net is that limited purpose specialty drug HRA. So if we can't get the drug for free from the manufacturer, then we'll run it through that specialty HRA, and we try to get whatever discount we can, the best discount we can on that drug. And sometimes that discount will be the best if we source that medication from Canada. So we use a company called Bundle RX, which is owned by RX Help Centers, to procure that medication from Canada and ship it to the member. And if all else fails and we can't source the drug from the manufacturer, we can't source it from Canada, then we get the normal discounts through our pharmacy vendor, Ventegra, and it runs through the specialty drug HRA. So the idea is nobody goes without their medication, but they do have to do a little bit of legwork. And so they have to work with RX Help Centers. They usually have to provide their some tax information, sometimes W-2. They got to get their doctor to fill out a form. So there's a little bit of work involved. And in return for that, at the end of the day, they're going to get their drug at no cost to them. So RX Help Centers has at times not been the easiest to work with. And it's a separate company from MedBen. So there's some interfacing that has to go on between Cheryl Morgan and RX Help Centers and MedBen. And when we first put this program in place, they were really the only vendor that we were aware of that was doing this kind of thing. But now there are other players, and including Ventegra, who is your pharmacy benefit manager, who works with MedBen on processing your normal pharmacy claims. So they have their own version of this now. It's called the Benefit Preservation Program. And we've got some clients who have transitioned from RX Help Centers to the BPP. And it's a smoother process for the member. And the reason for that is that it's because it's all under MedBen's umbrella, there's more coordination between them and the PBM. And we don't have to do this interfacing that we've had to do with RX Help Centers. And I think they're just a little better at hand-holding, to be honest. There's been some turnover at RX Help Centers with their account managers, and some of our members have not had the best experience. So there's been some frustration. But the BPP, I mean, we've got, I think, 2 or 3 different clients using them now, and they've had very little noise when they've moved to the BPP. They have their own version of the Canadian mail order program. I think it's called Rescribe. So we'd still have that piece. The pricing is a little bit different. I included the pricing in the materials. Instead of it being a flat fee per month, as it is with RX Help Centers, they base it on the number of scripts that are flowing through your plan. So, I mean, at the end of the day, it's going to end up being pretty comparable in terms of administrative costs. So, Brooke, do you want to add anything there?
Nope, I think you hit the nail on the head. We've had a lot of groups transition from RX Help Centers over to the Benefit Preservation Program with a lot of really good feedback, just because I think since it's integrated into MedBen RX, we know who the individuals are. It's more of an outreach to them versus leaving it up to the member to contact RX Help Centers. So our members seem to like that. They feel like they're proactively working on their behalf.
Yeah, no, as a employer who has had to watch an employee go through this process, I will tell you it is not easy. And having this change and having people on the inside who are more apt at being able to help would be a big benefit for members.
And as the account manager too, we do work really closely with the members. It really is a more streamlined process. We've seen a great, it's just really worked out great. So I can also recommend it too on the account management side of everything.
Anybody else have any questions or discussion on making this change?
So again, Lisa, you said the price is relatively comparable as opposed to the flat fees. It's just going to be based off utilization.
Correct. Yeah.
Yeah, I mean, I think it'd be great. I know we've had a couple members here, and again, I've heard of some struggles, especially with communication. And like you said, if we could streamline this, and it's about the same cost, and it's better experience for everyone, I would welcome it.
If there's any other discussion or thoughts? If not, I'll entertain a motion to make this approval or make this change effective 7/1.
I'll make that motion.
It's all
I'll second.
Tony's hand up. So, great. We have a motion first and second. If there's any other discussion? Hearing none, all in favor, please say aye. Aye. Any opposed? Okay, great. Thank you. Next item on the agenda is compliance update.
All right.
I think just
Are you seeing that or no?
no.
No.
There's always one more step that I'm missing. Brooke, do you have it pulled up? You want
Give me
Oh.
1 second.
Yeah, I don't think I opened it, so I'll have to open it. It'll take me a minute. Have a younger person give me an assist here. Thank you. Okay, so first, out-of-pocket maximums. So that's an ACA rule. It's the maximum amount of cost sharing that you're allowed to impose during the course of a plan year. So that's any co-pays, co-insurance, deductible, things like that, everything but premium. And then we talked about the change for Plan 6. So that's about a $50 increase on the single deductible, $100 on the family. The PCORI fees, I mentioned that during the financial report. So next year, well, this year in July, that fee will be $3.22, which is the same that it was last year. And then next year, they've announced that the fee will be $3.47 for covered life. So that particular tax is supposed to sunset, I think, in 2029. We'll see if that actually happens. The gag clause attestation, so that's a federal requirement that you have to comply with every year now. And you have to attest to CMS that you don't have any gag clauses in your vendor agreements. And gag clauses are provisions that would restrict you from disclosing information about the amount you paid for claims to specific providers. So MedBen actually took care of that for you. They did that attestation, I think, back in November. And then we talked about the new Kentucky mandates. And then I did want to mention on the ACA reporting. So all of you, because you sponsor self-funded plans, have to report to the IRS. You at least have to do the 1094B form to the IRS. If you're an applicable large employer, meaning one with 50 or more full-time employees, then you also have to do the more comprehensive C reporting. So I've got the deadlines here. A recent development has been as part of the Paperwork Reduction Act that Congress recently passed. You won't have to send out the individual forms to your employees as long as you provide them with adequate notice that if they want a form, they can request one. I don't know why anybody would want one, but if they did, you would have to let them know they could request that and you would provide it. Now, that's a very recent development and the regulators haven't fleshed that out yet. So I would recommend that you just carry on with what you've been doing for this upcoming filing and maybe explore not providing the individual forms next year. But the most significant thing is that if you provide 10 or more returns to the IRS, and by that, it could be a W-2, 1099 in the prior tax year, then you have to file your 1094B form to the IRS electronically. And you would think that would be an easy thing to do, but it's not. And Mr. Chairman, you can attest to that. So we do have a vendor who can assist you with that for a pretty nominal fee. So if that's something that you're interested in, let us know and we'll get you in touch with them and they can easily do it for you. So any questions on?
When you say that, Lisa, are you talking the city 1094, right? Who is submitting the 1094?
Participating entity.
Got it. That's what I was thinking. Okay.
Yeah. Yeah. So in the past, you could do it on paper. It was pretty simple to do. But now it has to be done electronically. But getting into their portal and getting set up is just a nightmare.
Gotcha.
Yeah, my city clerk came to me and said, can we use a vendor this year? So, because last year she gutted through it and got it on and through the IRS, and not a pleasant experience.
Right.
So,
Can you go back a little bit further on your page 4 there, Lisa, a little farther up?
Mm-hmm.
All right, good. Stop. Okay. All right, I'm gonna ask a silly question, maybe a stupid question.
Questions and health insurance.
First bullet point under 4. So how's that different than number 5? How are those?
Number 4 is a federal requirement. And number 5 is the Kentucky insurance mandates.
So they don't conflict with each other.
No,
Okay,
they're unrelated.
gotcha.
Mhm.
any other questions? Good to see we were compliant. All right.
It's not easy.
Yeah. And they change it all the time. If there's no further discussion on the compliance issue, I'll move on to the next item under the agenda. That's my item. It's the interlocal renewal update. When we formed this august body in 2014, it had an 11-year run on it. And so the interlocal agreement that we used to establish the health pool expires on 6/30. And so there is a new interlocal agreement that I have received from my city attorney, who just also happens to be the city attorney for Southgate, Mary Ann Stewart. She's also the attorney for the Northern Kentucky Independent District Health Board. And so she did a wonderful job putting together the interlocal. I've already shared it with Chris, and I'll ask him to get that out to everybody. At this point, what I'm looking for is for you to take this agreement to your legal and executive authorities and basically get it blessed by them. See if they have any changes, see if they have any questions, and we'll try and get those answered. And then if we do have changes to the document, I want to try and get those back from you as quickly as you can, so we can talk about it at our March meeting, because at the March meeting, I want to have a final document that we then give everybody so everybody can approve it between April and June 30, because we'll need to also file it with each county clerk. We'll have to file it with the Attorney General's office. We'll have to file it maybe with the Secretary of State's office. So it's going to require some running around, which I'm sure I'll be happy to help coordinate with the add-on. But this document does need formal approval by everybody, including the agencies that have just joined in the last couple of years. So we're starting it all over again. The only 2 changes in the document that I think we might have to have some discussion on is Mary Ann changed our name. So instead of being the Northern Kentucky Public Entity Joint Health Insurance Board, we would now be the Health Insurance Pool. And I think she just did that for clarity, to make sure that we weren't being accidentally confused with the health department. And I can live with that change, but I don't know about the rest of you. So I didn't want to say that one was okay without hearing back from you guys. The other one is that she makes the chair of the board the responsive party for custodian of records and open records requests. Me personally, as a certified master municipal clerk, I have no problem pursuing that role, but I'm not sure that the board chair is the right person to be the custodian of records when we have a secretary listed in the interlocal. So that might just be something that we have to talk about as far as which role is most appropriate for being the official custodian of record in the agreement. And then anything else you or your powers that be back at your jurisdiction find, we're happy to talk about them. So I'm sorry to talk about a document you don't have in front of you, but you will have it shortly. Any questions or concerns about this process?
Greg, if there's any changes or recommendations by any of the entities, do we just bring them to the March, or is there anything that needs to be sent out prior to that just to kind of iron those out before the March meeting? Or how would you like
Yeah,
that handled?
Yeah, as soon as if you know or your agency has some concerns with the document and want some changes, get them back to Chris Courtney and we'll kind of put them together and we'll try to work them out and iron them out beforehand, because again, it's going to be a lot easier to walk into that March meeting with a final draft than it is to try and hammer out the draft at that meeting.
Sure. Okay. Thank you.
And talk to your legal staff. For the special districts, it's not a problem. You only have to read it once. You have to pass a resolution for it. But for the cities and the fiscal courts, the state statute says by ordinance or by resolution. And some people interpret that to mean it has to be by ordinance. Others don't care. So I'm not going to track it. I just want to document approved. So check with your legal staff and see which way they want you to have it. You might have to have 2 reads on it as far as timing. But if you're like the municipal utility or the fire district or the fire authority, I think you can get by with 1 read because you don't pass ordinances. Any questions? All right. Hearing none, that's all I have on agenda items. So the next item is announcements and reminders. And our next meeting is March 21st. It will be virtual. Does anybody have any announcements or anything for the good of the order? Hearing none, I will entertain a motion to adjourn.
Motion to adjourn. Second.
One quick question. What was the date on that again? Kurt?
21st.
21st, March?
March 21st. All right. Motion made and seconded to adjourn. All in favor, please say aye. Aye. See y'all in March.
Thanks,
Thank you.
everyone.